Okay, well, we're going to continue into our next couple lightning talks. We're moving kind of into the political and legislative status and future trends. We get to hear Jay talk about President Trump and the impact that he may have on our movement. As well as, so Jay Keese, as well as Phil Eskew, we'll introduce in a second. So let me introduce Jay Keese. Jay Keese, as you guys may or may not know, is the heads up the Direct Primary Care Coalition in Washington. So Jay is heading up all both federal as well as state legislative efforts to try to grease the pad, so to speak, to allow DPC to be embraced more easily. And he's here to talk about what he thinks might be happening today, as well as where it may go tomorrow legislatively. Jay.
Thanks, Mike. How's everybody doing?
Excellent. We need a cocktail.
I can't hear that. So, as the last guy between, Phil and I being the last guys between you guys and cocktail hour, how is everybody feeling?
Yeah.
What does everybody think about these guys? Do they look happy?
For real? They need happy hour.
All right. I know it's San Francisco. You might be afraid of being bugged or anything, but just show of hands. Who in the room thinks President Trump had a policy agenda when he was running for office about what he wanted to do on healthcare? Just who thinks he had some ideas? Anyone?
Just had ideas.
Yes.
All right.
The answer to that is no one did ever.
Who thinks?
The answer to that is no one did ever.
No one did ever.
No one did ever.
Well, it's interesting because one of the things that was on the president's website throughout his entire campaign for president was his ideas about healthcare, which mirrored very much the other guy here, Paul Ryan, his ideas. And they were pretty well thought out. And the reality is, whether you like President Trump or not, whether you think he's a good guy or a bad guy, whether you think he's the devil incarnate or the savior of the next political movement, he had some very, very well thought out ideas. And those ideas were to take healthcare and drive it into a market-based healthcare system. And you've heard a lot of talk about that today. So we want to go through some things and talk a little bit about what the environment is. We all know how toxic it is. We all know how crazy it is. We'll talk a little bit about the bill that just died for the second time. The patient isn't even on life support anymore. It's pretty much dead, but expected to be revived a couple of times between now and the end of the year. And that's just the House bill, because things will then kind of go into the Senate. But there were three main ideas that the president had coming into office, and he may have a very hard time implementing them, but I think some of them do point in a different direction for where we've been with some of our top policy issues. Number one was he wanted to repeal the Affordable Care Act, plain and simple, except that he wanted to keep pre-existing conditions and young adult coverage. But everything else, gone. Number two, he wanted to move into a market-based healthcare a healthcare system that would use HSAs and allow people to purchase healthcare options with their HSAs. That was in the plan. And number three, he wanted to do some fundamental reforms to FDA and other areas of the government in HHS to make them more innovative. So those were the things that he talked about. And in fact, we've been moving, and we're moving before this, in some of that direction. So on his very, very first day in office, the president signed an executive order which essentially told all of the agencies in the federal government that they should be doing whatever they can do within their powers under the existing law, and the law of the land is the Affordable Care Act. So under the Affordable Care Act, to make the primary rationale for our healthcare system the reduction of economic burden and reduction of regulations. So instead of being the key motivator behind the Affordable Care Act, that was sort of stated in the bill and stated in the President Obama's vision of where the Affordable Care Act would be, being increased access to care, increased access to insurance, and changing some of the delivery models in care. Now the stated purpose of this administration is to reduce regulatory and economic burden. So there are a lot of powers within the law that was passed. The Center for Innovation from CMS allows you to waive any part of the Affordable Care Act to do a delivery reform that would result in improved access to care and reduction of costs and improved care. So sort of meeting that triple aim. Section 1332, anybody familiar with that term? Section 1332 waivers? That is a program that was written into the Affordable Care Act that would allow any state, governor, or legislature to pass a delivery reform proposal for their state, submit a plan with CMS, and allow any portion of the Affordable Care Act to be waived to carry that out. So the plan would have to be passed by the legislature, signed by the governor, and then sent to HHS, to CMS to be approved. So there are actively, probably, I would guess, 20 or so states around the country that are now looking at these 1332 waiver programs. There's been a couple of them passed to do Medicaid programs, to do delivery reform programs, and to do some interesting things. And there could be a big impact for direct primary care in some of these, because in some of these states, particularly now the 20, I love it when my slides are out of date after just one day, but the 21 states that have now passed direct primary care laws, you could see some of those impacts kind of waving into what might happen. I'm going to skip through a bunch of stuff here because we don't have a ton of time, and I know everybody wants to get to happy hour. But I'm going to talk about some of those states. This year alone, we have seen and helped to pass Arkansas, Colorado. Arkansas people, anybody here? Colorado. Thank you, Colorado. Indiana.
Yeah.
There we go. Kentucky. Anybody from Kentucky? All right, Kentucky passed a great direct primary care law. Virginia. Anybody here from Virginia? I know Matt Hayden was very instrumental, one of Clint's folks, in passing for the second time a direct primary care bill in the state of Virginia. This time we actually got the governor to sign it, which was a little bit of a surprise, I think, to all of us. And it's got some very interesting attributes. And I think Phil's going to talk a little bit more in detail about what some of those things are in the breakouts, and we'll go through some of them. But suffice to say, it's a very good development. And West Virginia, which probably had the worst direct primary care law on the books, changed it and now has turned that around to be a good law. So, what are I think some of our priorities? It's important to be involved. The Direct Primary Care Coalition is the primary group out there working solely on direct primary care policies, to try and advance policies that will help direct primary care to grow, that will help you all to be able to do your practices, to help businesses and employers have access to direct primary care. So we're really working in what I would call 3 different buckets. And the first bucket is, again, the legislation we're trying to pass in states, which essentially, all of it, in one way, shape, or form, defines direct primary care as a medical service that's outside of the scope of state insurance regulation. I think that's a policy almost everybody can get behind. There have been and are ongoing issues, inconsistency with the laws regarding the tax code and direct primary care. I think everybody in the room is probably familiar with one of the biggest policy barriers that we have right now, and that is that health savings accounts are fundamentally right now not compatible with direct primary care. It isn't just that you can't take your money out of your health savings account and use it to pay the primary care doctor. The way the code is interpreted by the IRS today, you can't even have a contract with a direct primary care provider and fund your HSA. So we are working very hard to get this fixed. We have legislation, HR 365, bipartisan bill, Representatives Eric Paulson, Earl Blumenauer, a Senate bill which will be introduced shortly by Senator Bill Cassidy, Dr. Bill Cassidy from Louisiana, and Maria Cantwell from Washington. So this is one of the very, very few things that people on both sides of the aisle in Washington agree on. We're also working directly with the administration now. We've had conversations with people in the White House, Treasury, and others about using that same executive order power that's out there, perhaps to have this interpretation changed in an administrative fashion. That's going to be a high hurdle, frankly, because in a lot of ways they're right. I mean, the way the law is written, it's a very, very difficult path to sort of justify how you would change that. essentially the IRS sees what you all do as some sort of a gap plan, like a Medigap plan, that gets in between a high deductible health plan and an HSA. And as you're probably all aware, the law today states if you have an HSA, it has to be paired with a high deductible health plan, and you can't have a second health plan. So even though we all know you are not a health plan if you're practicing direct primary care, the way the IRS interprets you, you are a gap plan that aggregates care in between you and your high deductible health plan and your HSA. And the idea behind the HSA was to have you take money out of your HSA and spend it fee for service on healthcare services. This law was written before direct primary care existed. It needs to be updated. The Affordable Care Act had a definition of DPC that included the words, this is not insurance, in the regulations. The IRS has not kept up with that, and the policy needs to change. More than likely, this legislation has a couple of possible vehicles that are very active right now. We have how do I avoid getting into the politics of this too deeply. We've been a little bit schizophrenic about whether or not we want to be in the healthcare bill that's before the House right now. There are so many things about the healthcare bill that's before the House right now that are problematic for practices, that as an instrument, as a vehicle of policy, there's things that could have impact, even if we got our provision in that wouldn't that would potentially be a serious problem. So that said, there is an ongoing effort by some senior people, both in the administration and Congress, to look at new avenues to this healthcare reform, particularly working with Senator Cassidy in the Senate, that might take a different approach. And we are actively trying to get this legislation, H.R. 365, included as a piece of whatever moves forward in a repeal and replace. Frankly, the more likely place for this might be tax reform, which is the second item on the president's agenda. And he's not having any easier time with tax reform, frankly, than he is with healthcare reform. So the pathway for this is convoluted. But the single best thing that we can do to show both the White House and the Congress that people care about this bill and want it included in a moving vehicle is to call your congressman or your senator and ask them to co-sponsor this bill. 202-225-3121. You can just do a plain old-fashioned call, or there's resources available on dpcare.org that'll help you find out where your congressman is. We would also all encourage you to come to Washington for the DPC Summit, June 15th through the 17th. June 15th, it's a Thursday. We're going to have an advocacy day on Capitol Hill. Those of you who have been there for our marches or on Washington, our fly-ins before, know that we cover an awful lot of ground. In January, those of you who were here, we did 80 meetings in a day and a half. We launched the first bipartisan health care bill, H.R. 365, of the 115th Congress. So it was a very successful visit. We need to come out and double, triple, quadruple the amount of co-sponsors that we have on the bill right now and get it to move. So my one ask would be, number one, that you call your senators and representatives and ask them to get on the bill, and if they are on the bill, thank them for being on the bill and ask them to move it forward. And number two, come to the summit in June and help us pass it.
Is that the same time as the AFP conference?
It's the AAFP and the Direct Primary Care Coalition and the Family Medical Education. It's all the same meeting.
Okay, good.
Yeah, it's the DPC Summit, and it's dpcsummit.com, I think. Or no.
Or
.org. Right. That's not the right. No, it's in Washington, June 15th. So there's a link to it on our website or on the AAFP website. Then to the state legislation. I know we're going to move on to Phil stuff. I did want to have the opportunity, because I think people are interested, to take a couple of questions.
I got one.
I'm not very smart on the government stuff, but if it's supported bipartisan on a bipartisan basis, why can't they just
Pass the bill.
throw it up for a vote? And
Yeah.
I mean, it seems like a no-brainer.
It does. Very little legislation actually gets done that way in Washington. So, anybody know what COBRA is? It's a healthcare proposal, right? So, you know what COBRA stands for? Consolidated Omnibus Budget Reconciliation Act. things like this often travel either in a budget vehicle or on a larger vehicle. I know everybody in this room understands that passing HR 365 can fundamentally change healthcare. Congress will not move it because it fundamentally changes healthcare. Congress will move it because it's a discrete change in tax policy that could help a burgeoning movement that they all, Democrats and Republicans, believe should be given a chance. So that's the way we've got to play this. And as such, it's very unlikely to have a provision that opens up the tax code to travel in a standalone fashion to allow that to go through the sausage-making apparatus in Washington and have lots of different things attached to it. So while we will take any opportunity to pass this by unanimous consent in the Senate and move it along to the House and send it down to the White House, that's a very unlikely way that it's going to unfold, just the way things work. No one over here.
So, kind of piggybacking on that, if this is truly bipartisan, why aren't there more sponsors like quickly? Like, so I live in Washington, so Marie Cantwell, why isn't Patty Murray sponsoring it with her? And why
You should call Patty Murray's office tomorrow and ask her that very question.
Is there other?
I think the answer to the question is that we do need to be more involved and more active. We need, there are resources on the Direct Primary Care Coalition website. Another show of hands, how many members of the Direct Primary Care Coalition are here today? We would love to see everybody else in the room go to the website and click the join button. It's one of the most important things that you can do to say that you want to support these policies. And the other piece would be come to Washington in June and help us get there. I think if we're going to be in the middle of a lot of stuff that's happening on this, whether it be tax reform or repeal and replace or other issues, it's going to be a really good time for people to come in and ask reasonably for Congress to move forward with a bipartisan bill. And I think that's about all we got for now. I'm going to hand it over to Phil, who's going to talk a little bit more about the regulatory stuff, and we'll go from there.